Hi, my name is Dr. Draman, and through the Oral Health channel, today we're going to be talking about orthognathic surgery. Let's start. Welcome to the third part of the orthognathic series. Now let me tell you that osseous genioplasty is not only just a procedure for functional correction, but it is also mostly an aesthetic correction of the chin, which is also known as chin augmentation surgery or chin reconstruction surgery or just chin surgery. So a lot of people from the entertainment industry who are basically very much conscious about their facial appearance because of the fact that they're public figures and need to be there out in public undergo this procedure electively. So usually it is a cosmetic surgery, and also it can be also a part of the orthognathic surgery with the help of BSSO or the Le Fort 1 osteotomy or the Bayes surgery. But in most of the cases, it is usually a chin augmentation surgery, which basically is an elective procedure which can be done under general anesthesia or local anesthesia to either advance, set back or change the cant of the chin so that the reconstruction gives a more aesthetic profile. Now coming to the acceptance of aesthetics when it comes to the chin, it also has a lot of cultural variation. In the Asian culture, it is considered that a small, a more recessive, a little acute chin which is slightly pushed backwards is considered more aesthetic and feminine. In the Western cultures, it's the opposite, and the more prominent chin with the jawline which is more squarish is considered more masculine in most of the cultures. Depending upon the demand of the patient and the kind of deficiency that could be present, either the chin is deficient or there is an excess. It could be a horizontal excess or a vertical excess or just plain asymmetry of the chin. Depending upon the defect as per the patient's perception and the oral surgeon's perception of either a horizontal or a vertical excess or deficiency or a change in the cant because of the facial asymmetry, the patient undergoes general anesthesia, and then we anesthetize the area locally with the help of blocks, and we place injections in the vestibular mucosa, and we start off the incision at the below the mucogingival junction of the teeth, making sure that we spare at least 4 to 5 mm distance from the root apices of the canine and the premolars, because that's where the mental nerve exits the mental foramen and goes upward with the mental with an upward trajectory. At the same time, to make sure that there is no paresthesia or any complications or any sort of injury to the nerve, we make sure that that distance is maintained. We give a W-shaped incision and then go for a subperiosteal dissection. I'm not going to go into the details of the anatomy. Just we undergo subperiosteal dissection and expose the bone completely of the chin protuberance, and thereby after that with the thin burr we put a midline, a small drill, so that we mark the midline, so that once we reposition the chin, we are able to get the midline with the facial midline in alignment. Once this is done, depending upon the requirement, either if it's set back, we will do the osteotomies, horizontal osteotomies, which start from basically your premolar to premolar with the distance being maintained, and with the help of a reciprocating saw we just start cutting and separating the chin bone, making sure that the muscle attachments are also being preserved, at the same time being dissected, and we join the two osteotomy cuts till the point that the whole fragment becomes mobile. Now usually it is more of either advancement. Most of the times, if there is an advancement, you advance the chin and you see everything else, that all the landmarks are falling in line and in proper fashion, and then you screw them with precision screws or just plates, and you add whatever the deficient amount of the gap is left. You add alloplastic graft materials or bone graft or bone substitute materials so that it heals and the bone is formed around it. If it's a setback, you make sure that you cut the amount of bone that is required for the setback, and then you push it back, and then you put position screws or plates. If it is just the asymmetry condition, you probably would want to shave off a little bit of the bone from the side where it is a little more excess, and you just rotate or derotate, whatever the thing might be, it into position, and then you place the position screws and the plates, and then you close it up with resorbable sutures, and then you put a compression bandage. The patient goes into the post-operative care where the patient wakes up from general anesthesia. The medications are started. all the precautions are taken care and all the instructions are given, there is definitely some post-operative swelling. There are chances of risks as well, something like known as paresthesia or anesthesia because of the mental nerve. It usually is transient, but 3.5% it has been found that it might be unfortunately be present for a very long time in a lot of patients. But then again, the results after that, after the results come out, the results are very aesthetically acceptable. There are chances of relapse, but usually it's not more than 2 mm, and it happens over years. That depends upon the kind of surgery the surgeon does and what kind of caliber or credibility the surgeon carries. So that's it for today. This was today's episode. Please like, share and subscribe, and do press the bell icon for important updates. If you want to get in touch with me, here are my social media handles and my WhatsApp number. However, I would request you humbly not to call me directly, as I might be busy with a patient, or otherwise just drop me a message and I can get back to you within 2 days. If you have any queries, apprehensions, doubts, questions, or any sort of suggestions, please feel free to put them in the YouTube comment section. So that's it for today. Thank you.